This is a little presentation I give to my EMT classes just about basic ECGs so they can understand a little bit of what's happening when they're on the truck and they see somebody get put on a monitor. If this is a very crude drawing of a heart, sorry, I'm not the best artist. We have up in the upper right corner in the right atrium, we have the SA node or sinoatrial node. At the junction between the atria and the ventricles, we have the arterioventricular junction, or AV node. And then moving down from that, all the little fibers down here in the ventricles are the Purkinje fibers. And what happens is you have a sympathetic and parasympathetic nervous system control to the SA node. And those two keep this beating or sending an electrical impulse at about 60 to 100 beats a minute. Remember, the sympathetic nervous system speeds things up, and the parasympathetic nervous system slows things down. So it's kind of a tug of war between the two to keep the rate between 60 and 100 impulses per minute. So when the SA node sends out a signal, it will come down through what they call internodal pathways, and it'll come over to the left atria and down here into the right atria, and it comes down to the AV node. And in the AV node, it will pause slightly, and that allows the atria to contract fully and push the blood down into the ventricles. Then this comes down through the bundle of His, and into the right and the left bundle branches. There's actually even a posterior bundle branch there. But if you've ever heard of someone with a bundle branch block, it means one of those is blocked. So from here, the impulses come down to the bottom of the ventricles, kind of around to the backside, and then cause the ventricles to contract. So we have atria contracting and ventricles contracting. So if we look at this on a monitor, because this is all movement of sodium and potassium and electrical impulses, we can actually trace this. And when we have the P wave, the first little bump there, that is when the atria is contracting. The whole QRS complex is the ventricles contracting. And then the T wave is when the ventricles are repolarizing. So we have, if we're looking at it electrically, we have atria or atrial depolarization, ventricular depolarization, and then we have ventricular repolarization. And a lot of us will kind of equate this to flushing a toilet. So the ventricles, when they depolarize, it's like flushing the toilet. And then it takes a while for the tank of the toilet to fill back up before you can flush it again. And that's kind of what's happening with the T wave. And I'm not going to get too deep into the sodium and potassium pumps and the movement of ions. We'll talk about that more in paramedic school. But if you're interested in that, there's a whole lot more to it than what I'm saying here. But the atria depolarization is the P wave, and it repolarizes actually kind of right here in the middle of the QRS complex, so we don't see the atria repolarize. The QRS complex is when the ventriculars are depolarizing or contracting, and then the T wave is the ventricular repolarization, or when things are kind of returning to their resting state. So if we look at a regular rhythm, this is kind of what we're looking for. We call this a sinus rhythm or a normal sinus rhythm, and you'll see that every complex has a P wave, a QRS complex, and a T wave. And if we, there's a lot of rules that go into it, but this is what a normal rhythm would look like. Now this is one that's maybe a little more important to you as EMTs, because when we see ventricular fibrillation, we need to use an automated external defibrillator. So ventricular fibrillation is all these spots in the ventricles are just randomly firing off their own electrical impulses, and it causes this very chaotic looking rhythm. And because different parts of the ventricles are trying to contract at the same time, it's very disorganized and there's no movement of blood out of the ventricles. So it's just sort of sitting there quivering. And that's the indication for, This is when we'll use an AED. An indication for an AED would be someone that's in cardiac arrest. When we attach the AED, it is looking for this rhythm, ventricular fibrillation. And if it sees it, then it will charge up and tell you to shock. The other rhythm that it will sometimes shock is ventricular tachycardia. And this one is kind of a wide, kind of ugly looking, doesn't look anything like the normal sinus rhythm. And this sometimes has a pulse, sometimes does not. So I've had a few patients that I've put on the monitor and been talking to them, and they're actually in this rhythm. And it's always a moment of, oh my, that's not good. And of course, don't say that to the patient, but realize that this is a very serious rhythm. And they will not probably be in this rhythm long before they go into ventricular fibrillation. But they may still have a pulse with this. And that is the reason why we never put an AED on a conscious patient. Because even though they're having chest pains, you're looking great, having the big one, you think they're going to go into cardiac arrest at any moment, we don't attach the AED yet because they might be in this rhythm with a pulse, and we don't want to shock someone that has a pulse. But if they are unconscious, unresponsive, not breathing, no pulse, and we attach it and they're in VTach, the AED should recognize this rhythm and shock ventricular tachycardia, just like it would ventricular fibrillation. Now, another rhythm for cardiac arrest is called asystole. And A means without, and then systole is contraction. So this is without any contraction. We just oftentimes call this flatline. And this is usually what we consider a terminal rhythm, meaning that if somebody's in asystole, there's not a whole lot of hope they're going to come back from it. There are cases where it does happen, and maybe some special circumstances, children, somebody young, cold water drowning, we might go ahead and try and do this, resuscitate somebody in asystole. But a lot of times this means that there's no energy left in the heart. The cells don't have any glucose and oxygen. They've used up everything they have, and they're just laying there flatline, not doing anything. So if the AED is attached to a patient in cardiac arrest and they're in asystole, the AED will say no shock advised, check pulses, begin CPR, or check your patient, or might even say just begin CPR. So that is why we would want to start CPR when the AED says no shock indicated, because they might be in asystole and they need CPR. So there's a little bit about some rhythms that you encounter as EMTs. Again, remember normal sinus or sinus rhythm, ventricular fibrillation, ventricular tachycardia, and asystole. So I hope this helps with your cardiac studies.